Okay, and it is right at noon, so we'll get this thing kicked off. Okay, all these little buttons to push. Okay. All right, we are now live. So I'm very excited. This is Jim Morgan. We're with Life's Copilot. It is a service that we provide from Caring Transitions, which that's our day job. And so, but today, what Life's Copilot is purpose is to get information out to seniors' families, their caregivers, and the caregivers around the industry that work with them to try to help us all understand better how to do all that stuff, what programs are available, how to access them, what things to look for. And today I'm really excited because I met these two doctors. I don't know, a couple of months ago or whatever at a senior conference, and they're doing some really cool ideas. They got some really interesting. Both of you, from what I understand, were like geriatric care doctors. Is that correct?
Exactly.
So with that, I want to bring them in and let them kind of talk about what they have in mind about how to create a more comprehensive, more cohesive environment for seniors and their care. So I want to introduce real quickly Dr. Patrick and Dr. Diane uh, Healy, and my glasses, I'm having trouble seeing that. But anyway, so anyway, I want to introduce you guys. Tell us who you are, tell us what your background is, and let's kind of get visit a little bit.
Right. I'm Dr. Diane Healey.
I'm Dr. Pat Healy. I'm the other Dr. Healy.
So we are married and have been married for many years now, but we've also worked together. So we retired now about 3 years ago, but we are geriatricians. So we are physicians, internal medicine doctors, but trained in the care of older adults. And we worked for 35 years. By the time we were finishing our work at St. Vincent Center for Healthy Aging, we really did a lot of care for people and their families who had a lot of comorbid diseases and dementia and frailty. Those were the people who we were finding we could help most. And as we get away from that care, because we're retired, we still see out there such a need for connecting everybody so that we all understand the whole aging process a bit better, and so that maybe we can navigate it a bit better as well.
Yeah, so we sort of began our journey in medical school, meeting early in medical school, and we worked together. Geriatrics was what we chose to do because there weren't many people doing it. It was a huge challenge, and of course, everyone knows the demographics. But the challenge with geriatric medicine is making the services available to the people who need it and identifying what the needs are. And this project that we do now, in our retirement, Healy's on Aging, is basically trying to take the age-friendly concept and operationalize it for people in the community, for professionals, and anyone who will listen. Because after practicing all those years in a very multidisciplinary fashion, the age-friendly concept just blew us away the last several years that we were in practice. And so that's kind of what this lecture is all about, is introducing the concept of age-friendly care, which is very exciting for
It
us.
is very exciting. Well, I will tell you, as a consumer of senior care, for years I've been, we were the only siblings that stayed in the state. So that required us to be dealing with a great deal with my in-laws, my parents, my uncle, what have you. And trying to get all the players on the same page is maddening.
Absolutely, absolutely. And it's the sort of information you actually don't necessarily pay attention to until you need it.
Right.
Mhm.
So it's not something that people are looking at unless it's their profession, their career, or whatever. But as a consumer, it's not something people really look at till they need it. And then they don't know where to start and how to begin. And we have
Well,
some thoughts on all that.
go ahead. Yeah, go ahead.
No, I mean, well, do you want us to go ahead and start now, or do you have
Yeah, go
other?
right ahead.
All right, so I'm going to share our screen here. Um, and let's see if technology works for us here. Uh-oh. We practiced this once and it worked. Let's see, maybe there's one more share down there.
There we go.
There we go. We got it. We got it. So what we've entitled today is connecting the dots for companies working with seniors, because we understand a lot of people that may be listening today are, that they have a company that works with seniors or is part of their profession, caregiving or whatever. But even if not, consumers need to understand this information, whether you're a friend, family member, or yourself aging. And part of the problem is that none of us know how to do this. None of us know how to do it correctly because aging is a new phenomenon. And I know that sounds a bit crazy, but it is. If you were born in 1900, your life expectancy was 47 years. Okay, 1900 doesn't sound to me like that long ago. Now, I'm one of those people aging, but 1900 is not that long ago. If you were born now, your life expectancy is 78 years. Okay, so there's a huge increase, which is amazing in that short time frame. So we've known over years individuals who might age, but never before have we had populations aging. So we don't know how to take care of populations of people, large numbers of people, all at one time. And so with this whole aging process, it's very diverse. It's not like we're all the same. You never take the wrong grandma or grandpa home from the hospital. You know who they are. Used to be, you might take the wrong baby home from the hospital because babies are much more homogeneous than older adults. But it's a diverse population, whether you're talking culturally or which diseases people may have, et cetera. So what happens is that we are now living through things that we would have died from previously at younger years. We have antibiotics, we have vaccines, we understand public health. We have better cardiac care with all the information that began in the 1960s that allowed us to live through things we wouldn't have lived through before. So the good news is we're living through all these things, okay? The potential questionable part is as we live longer, we have the ability to accumulate chronic diseases. What's a chronic disease? A chronic disease is a disease that doesn't go away after about 3 months, okay? So what kind of diseases? All of you could probably name some of those, whether we're talking diabetes, hypertension, high cholesterol, decreased eyesight, decreased hearing, osteoporosis, osteoarthritis, you name it. And we don't know what combinations of these things any one individual may get. We may have a little control in our lives over what sorts of things that befall us, depending on our lifestyle, our habits, et cetera. But things happen no matter if you've been doing everything exactly like you would have done otherwise. So this is considered, when we develop these chronic diseases, that's called multiple chronic conditions, okay? And over that time, with the multiple chronic conditions, we have things associated with that, whether that is, forgot to show you this slide earlier, with those multiple chronic conditions, it means our quality of life might not be as good. We might be moving a bit more slowly. Our energy levels may not be as good. Our thought processes may not be as quick as they were. We may be on more medications, end up in the hospital more, need more care. A whole host of things can happen as we develop these multiple chronic conditions. And with that, then, we may become more frail. And frailty is kind of a new concept. Again, this whole aging is new. So for physicians, for nurse practitioners, for care providers, frailty isn't necessarily a word that was bantered about even a few years ago. And you may not always hear it now because we are all taught to think about acute medical illnesses and to treat one disease at a time. But what happens when we have 10 diseases at a time? Things may look differently when we have 10 diseases at a time. So we have to figure, how can we look at each individual, because I don't have a textbook that's going to help me here. So this might be a little bit of a complicated slide, but we're going to walk through it, because if you are older adult, whatever that age might be, whether that's 65, whether that's 85, And if you have just a couple of chronic conditions and you're fit and functional and doing everything you want to do and you're feeling great, you need to, with your care providers, continue to follow that disease-based guidelines, meaning we know how to treat diabetes, we know what your levels should be, we know how to treat your heart problems and cholesterol, et cetera, et cetera. Go for it. Keep doing that. On the right-hand side of this picture, if you have advanced end-stage disease, such as a dementia, a cancer, congestive heart failure, and you have been told that maybe your life expectancy is limited, maybe you have 6 months or so less to live, maybe you're on hospice, we hopefully are talking about such things so that we understand the care. It's these people in the middle that all of us who work with older adults, whether it's our profession or whether it's as a family member, where we really need to begin asking a lot more questions. Because if you have increasing number of conditions, your function, your mobility may be impaired, your ability to live at home independently may be impaired, and you may need a whole host of services brought in so that you can stay there. These are the people that need some different current care planning. What's important now? How are we going to look at things differently? Because to treat your diabetes like we did, if you had no other problems, ends up being totally different than if you have 10 problems. So things can look quite different. You look like you have something to jump in and say right there. So to help us out, in comes this whole concept that Pat was referring to as age-friendly care. In about 2017 or so, a group called the John Hartford Foundation and the Institute for Healthcare Improvement both realized, these are national companies, not-for-profits, that realize that we all do a horrible job of providing care for older adults. Why? Because we don't know how to do it. We've never had to do it before. This aging thing is new. So here's the evidence-based medicine, okay? So again, when you see your doctor, they're using evidence-based medicine to treat your single diseases. But when you have multiple diseases as you're getting older, that evidence-based care that these two groups went together and figured out has to do with what we call the 4 M's. The 4 M's are what matters: medications, mentation or mind, and your mobility. These are the M's, and Pat's going to talk about those in just a little bit, in just a moment here. But this is the information that all of us listening need to understand, okay? Whether it's for your own company or if you're for your family member or whatever. And as we talk through this day, this whole connecting the dots we're talking about is how can we share this information among each other? And we'll kind of come back to that a bit more as we go. We also have to remember that part of this whole, we're kind of talking medical in a sense, but we're getting away from that a bit as we talk 4 M's, but you also layer on top of this something that we call the social determinants of health. It's not just about your medical illness, but what's your living situation like? You know, what are your finances like? What's your ability to get around? What are your health habits like, et cetera? So all these layer upon your medical care. And with this, I'm going to let Pat take over and kind of walk us through the 4 M's here just a little bit.
I think it's real important to realize that, the concept of health, only about 20% of that has to do with medical care. The other 80% are these social determinants of care. And so the age-friendly concept brings about not only care of the medical conditions, but also of what is important for the aging individual and maintaining function and quality of life. So, in our practice, I said earlier that, we're very multidisciplinary, but when this concept of the first M, which is what matters, this was the one that was just mind-blowing to me and changed my whole concept of how I related not only to patients, but also to their families and their caregivers. So what matters? What matters is two parts. One part I think everybody knows, and that's advanced care planning. And everyone regardless of what your age is, should have, a power of attorney for healthcare and finances, and should have a power of attorney, et cetera, and have talked about what, end of life, what you want that to look like. And I think, most physicians and care and providers do make sure and advise that you have this. What's new about what matters is what we call current care planning. And current care planning is what's important to you. Me as a clinician, using evidence-based medicine, I want perfect blood sugars. I want blood pressures where it belongs. I want cholesterol within a certain number of, of numbers, et cetera, et cetera, et cetera. But I get blown away when I have, 6, 8, 10 diagnoses that I have to deal with in a visit. And I don't necessarily know what's most important to you unless I ask you. So the big thing that happened is with what matters is me as a clinician asking the patient or the family or the caregiver, what's most important to you? What do you want from your healthcare? What do you want me to do? How can I facilitate a better quality of life? Now, when you ask that question, you get the most dumbfounded look from patients, families, caregivers, because no one's ever asked that. And oftentimes you get no answer whatsoever because, you have to think about it. Well, what's important? Well, doctor, I'm here, I want you to tell me what to do. Well, I'm board certified good at keeping your numbers where they belong, but is my care burdensome? And one of the things that happens, and again, asking this question, and you don't just do it once because it's a beginning of a discussion. You ask it again. And oftentimes when people come back, they have a much better idea of what matters. What is important to you? Is my recommendations for healthcare excessively burdensome? But nobody ever asks that question. And based upon what you're interested in, what's most important? And oftentimes the answers you get are, I want to stay independent. I want to be on less medicines. My medical care is burdensome. Or my favorite, I want to feel good every day. And you gotta remember that this population, they've already achieved their life expectancy goals. Now it's about, what do you want from your life? What's important to you? Not for me and my evidence-based guidelines, but what's important to you so that we have a discussion back and forth. And that's what's so rich because it's shared decision making. It's not just me preaching, but I want to hear what's important to you. What are my goals? And then we discuss those goals every time we're in the office. What is most important to you? Okay, and that may not be tight blood sugar control. Now, if it is, I'm board certified good at doing that. But most of the time, it's function-based, it's quality of life-based. And so everything that we do in terms of our medical care is aimed at what matters most to you. So these needs or these desires may change. This needs to be brought up regularly. And it's a great conversation. And I'm telling you, it's amazing how families and patients and caregivers really love that I asked that question, that we began that conversation. So your medical team needs to know what matters to you. And when you go to see a physician or a nurse practitioner or a care provider, have a list of questions at each visit, okay? And talk to your family about what's important, okay? And you should talk to all your physicians, okay, or all your providers, that everyone knows what is most important to you. Because as we have the siloed healthcare system, your primary doctor may know this information, but your cardiologist and your orthopedic surgeon may not know this. But you need to communicate it to all levels. Okay, so I think we'll do the next slide. So here's some resources, and I love this online tool, My Health Priorities, because it's part of the, once you bring it up, you say, go to this website, and it will very simply take you through all the information about what matters. And then at the end, you can print it up and you can use it as a reference in terms of what's important to you, and you can give it to your provider. And you can also change it. You can share it with members of the family. You can share it with everyone, but you get an idea of what's important. Okay, and it may not be medical. Okay, the other one is the Conversation Project, which many of you may have heard of, which is a wonderful way to begin talking about current and future care with family and caregivers. So what matters was just an amazing inspiration when I started doing it in terms of communicating better with my patients and their caregivers.
Okay, I'm going to jump in here at this point. So Pat is sounding like this is going to happen every time, your client, your family member, you go to the doctor. That is not the case. Okay. This is all new enough stuff that if your doctors are asking it, that's wonderful. That's amazing. If they're not asking it, it doesn't mean they're bad. Not at all. Again, this is new stuff. And one more thing to discuss at a doctor's appointment and take time. So one of the whole reason for our discussions with you today, if you are a care provider in someone's home, you can encourage them to get online and go do one of these, My Health Priorities or Conversation Project with their family. And they can at least have that way discuss this information before and maybe even leave it out. Well, for sure, take it to other doctor's appointments with them, but leave it out so that if any of you are part of their care team in their home, you as well know what's important to them. It's not that you're going to take over their diabetes and treat diabetes, but you know that their goal is, what matters is to stay home as long as possible. Well, that may make a huge difference to Jim and his company and many of you others out there as well. So this is the sort of thing that we will kind of keep talking about as we go on today, about connecting the dots. How can we all connect the same information on this one person so that we're all working, towards that same goal, as opposed to in totally different, realms that never speak to each other.
All right. I'm going to interrupt for just a second. One of the things that, this asking the client what they want and what their needs are, this goes back to I come from a sales background, and that has been my training for years is, the old axiom in sales that they like to try to teach is feature, benefit, close. And I've always argued that there is no feature that has any benefit till you find out what their needs are. Okay. So, you could just be throwing up on them all these different programs that are available, but unless you find out what they want, it doesn't make any difference. And so I definitely see where that comes into that funnel. You start asking these questions so that you can come down to what their desires are. What we spoke of and I'm just want to bring this up because it was very fresh to me, okay, is what we spoke about right before we went live was that I'm just going through that with eyeglasses. I had no idea that I had any issues. I noticed a couple little minor things that were bugging me. I went in to have it checked and was actually freaked out by how little I could see on the tests. 3 years ago, I didn't have that. And so I got terrified when I heard all the verdicts and all this kind of stuff. So for the last month, I've been trying to force myself into these things that they've been trying to prescribe for me. And one of the people at the front desk gave me permission that I didn't have to fight it that hard anymore. And it was like this taking a Buick off my shoulders. Okay. And then I actually had some time to think, what do I want? No one asked me, but I had a time to think. And what I realized is I need to be able to see driving better, and I need to be able to see some stuff on my computer better. My readers work fine for reading. I don't really need that. I'm perfectly content with that. So rather than trying to fix all of it, which was causing me unbelievable stress and none of it was working, I'm now attempting to fix this and that. And we'll see if it works. But it literally was this it was amazing. It was literally this massive weight that came off my shoulders. And I'm like, these are the only things I care about. Why am I putting myself through all this, for this? So that's exactly what you're talking about, so.
Absolutely. Especially when you have 10 diseases, which can truly happen, or even if you only have 5 diseases. And if you're trying to treat each of those diseases individually, the number of medicines and then how you feel on all those medicines, et cetera, it may mean that, oh my gosh, it's just too many things at once, and the goal is not getting us where we want to. If the goal is blood sugar at a specific level, fair enough. But if the goal is I want to feel good, you might not be getting there at all, or we may be making it all worse by, trying to, get to too many places at once. So this really is just such a helpful piece of information. And again, I feel that everyone out there working with older adults, that this is a useful piece of information.
Yeah, thanks, Jim. That's a real live example of what matters. Thank you.
Well, quick jump in before Pat takes over again. This picture or icon you see on the right-hand side, the main reason I throw that in all these slides is now that you've heard this concept, age-friendly care, in different places, you may begin to see this icon, because this really is a social movement across the U.S., actually across the world, from the people who kind of put it all together. So you may see this, and if you see this pop up in some article you're reading or literature you're reading, take note. What are they talking about? Maybe something that you have heard today or something you want to know more about.
All right, is it time for the second M?
Yeah, second M.
Second M. Okay, let's do medications. So again, as we accumulate a variety of chronic conditions, we accumulate potentially a great deal of medications. And as we age, as we get older and our needs change, oftentimes the medications that were fine 10 years ago may not be fine today. And oftentimes I think, we as providers are very good at identifying all the medications, but whoever asks, what exactly does each medicine treat, and is it doing the job it's supposed to do, and potentially what side effects are going on? And I think one of the things that the whole concept of looking at medications is to say, all right, do we still need this medication? Is it consistent with what matters to you? All right, because you've already got longevity, you're already there, and could it be potentially harmful, or is it potentially interacting with other medications or other diseases? So the whole concept of let's look over the medicine list. Let's make sure that the medicine list is consistent with our what matters and is not being potentially harmful. One of the things that we found out, through experience, was that as physicians, we're very well trained, and nurse practitioners, to prescribe, but no one ever, informed us about the concept of de-prescribing. The concept that maybe some medicines are no longer necessary and can be de-prescribed, taken off the list. And I think, medication lists are problematic. And, everybody thinks that my fancy computer has the right medication lists, or the people at the pharmacy do, or wherever. They don't. Only list I ever believe in is a list that the patient or the family caregiver brings in and says, this is what we are taking. Okay, because there's so many different medication schedules out there, it's easy to get screwed up, and you've got numerous providers. So I recommend that people have a list on their person at all times, and especially when you're with providers, this is the medicine list that's real. And it's okay to go to your physician or your nurse practitioner and say, let's have a review of the medications. Are there any medicines that we could get rid of? And maybe are no longer necessary or might be problematic. That's a good reason for an office visit. And I think, I want to empower people to say, listen, it's important that this medicine list is right, and let's make sure that we're on the right medications and it's consistent with my goal in terms of what matters. Okay, so what kind of resources can,
And just a quick question for you though, Pat. If I think that my medicines might be causing problems, can I just stop them myself?
You don't want to stop them yourself. Okay, thank you for that. You want to be sure that you have worked with your provider to be certain, because you might be stopping the wrong medication. So it's a good idea to ask for a review of your medication list, but don't do it on your own. That could be potentially dangerous. But it is okay to ask your provider, can we look at the medicines and line up what medicine one is treating, the the correct diagnosis and just lining that up. There's some resources here, and this is the Health and Aging tip sheet, 10 medicines to be avoided. And then the NIA has this worksheet for tracking your medications just to help keep it straight. And also, I think, we need to know which medicines are treating what diseases. And is it something we're on for a lifetime, or is it something that we're only on for a short period of time? So it's okay to say, listen, let's look at our medicine list and make sure it's consistent with what matters and what our goals are. Okay.
And for those of you listening in, if you are a company that you're in people's homes, you might also help only in the fact that, sometimes we find that there are medicines all over people's homes, and, things are in total, disarray. You might, not that you're going to take over and do anything specific with that, depending on what you are in that home doing, but you might ask someone, whether it's the patient or their family or whatever, to take stock of their medicines, make sure they go talk to their doctors about it, et cetera, especially if you're seeing things all over the home. That's one of those signs that we may have a problem.
All right, it's time for the third M, and that is mentation. And when you have a patient who has multiple chronic medical conditions, oftentimes the last thing you're concerned about is mentation. And what I'm talking about here is cognitive decline, dementia, depression, and what we call delirium, which is acute confusion. Oftentimes, these are missed in a medical office visit, okay? Or the patient and or family thinks that the physician knows about some cognitive declines, okay? Oftentimes, my experience is that the last person who knows that you are having cognitive problems is the physician, okay? Because we often don't ask the questions, we don't screen for it, and we often talk about the same things we talked about, 6 months ago. And if you're a Cubs fan, I know that your Cubs always lose, and as long as we agree, I assume your cognition is normal. Well, it may not be. So as a caregiver, as a provider, you need to tell the clinician that there is an issue, whether it's decline in mentation that's affecting function, whether it's depressive symptoms. And again, depression is something we don't like to talk about, but it's extremely common, more common as we get older. And it's also very treatable. But it's oftentimes people won't want to admit it. So I think being open about, symptoms of decline in memory and function, decline in quality of life, and spirits is something that needs to be brought up. And oftentimes it's not. Okay, delirium is just acute confusion brought on by acute illness or by maybe a drug side effect. And if that happens, that needs to be brought to the attention of the clinician. Okay, so basically, this is a reminder that it's not just all about medicine and medical things. The level of cognition and function and treatable depression needs to be brought about because it's extremely common.
And your role, if you are someone providing care in someone's home, even if you're a non-medical provider, even if you're not the home care company, if you know this person because whatever it is that you do with them, you've known them for a while, you've been in and out of home, and you see something different today that's really different, I would ask you to make sure you let someone know that day, boy, Mrs. Jones is really different today. Something real, can happen quickly to cause this delirium that Pat is talking about. And it may be the sign there's an acute illness. So those of you in and out of homes, again, what we're trying to talk about today is making us all connect the dots. How can we all help in the same situation? Not asking you to diagnose anything, but often you're the ones who may see something well before anybody else picks it up. And in older adults with multiple chronic conditions, this can be a big deal. And the sooner someone reports on it, the better chance you'll have of finding a cause and doing something about it.
Okay, and then in terms of resources for mentation, the Alzheimer's Association website, alz.org, is just incredible as an information store. Managing delirium in older adults is a health and aging tip sheet on acute confusion. And then the National Institute of Mental Health has older adults and depression, learn the signs and find treatment. These are just some resources for you. But I think the biggest thing is that, if you're noticing issues in mentation, bring it up, because oftentimes it won't show up in a usual doctor or nurse practitioner visit.
And even though I was saying sudden changes, if you're the only one noticing slow, things, or that someone's having difficulty doing what you're asking them to do, and they should be able to do what they've done it before, again, whether you're letting family know or whatever your position might be there.
All right, and the fourth M, and this is often thought to be not that important. But if you ask what matters, most of the time, the answers you get aren't medical goals, they are functional goals. I want to stay at home. I want to attend my granddaughter's graduation. I don't want to be dependent. I'm afraid of falling, etc. Mobility is something that is probably under recognized as being as important, because when you're young or when you're fit and functional, mobility is just a given. Everyone does it. But when you start losing it, or you start falling, or becoming fear of falling, then the whole issue of mobility becomes extremely important. And maintaining mobility is often key in fulfilling what matters. Okay, so we need to have an idea of what activities are the patient or the client is doing, what they used to be able to do and what they cannot do now, and identify it early. One of the things I did in my office, and I don't expect everyone to do it, but I did the get up and go test in my office on everybody, every single visit. And what the get up and go test is I had the patient get up out of the chair, walk across the room, turn around, come back and sit down. And we did that every time. And I can't tell you how many physical therapy and occupational therapy referrals I made just on the basis of watching somebody walk. In a typical doctor's office, oftentimes the only one who sees them walk is the nurse bringing them in, and the physician has no idea that there are mobility issues. They can no longer get up on the bed, or they're falling. If you don't ask that question, or if someone doesn't identify it, and again, people going into the homes, if they're noticing mobility issues, that needs to be brought up. That is extremely important. Don't just expect that the clinician is going to know about it, because the clinician may have too much on their plate, and if you don't bring it up, it doesn't get mentioned. So, anyone that's had a fall in the last year needs to be screened for mobility issues. We need to do physical therapy and occupational therapy before they fall, before they break their hip, and again. We need to create an environment that enables mobility, and many of you who are out there, that's what you're doing. But if you see declines, that needs to be identified. Because you can improve strength, flexibility, and balance. You can do that. It's not like just because you're old, it doesn't happen. You can improve your function based upon working with mobility. So the falls-free checkup from the National Council on Aging, home safety tips for older adults, and exercise and physical activity. One thing I always said that, physical activity is something that people do when you're young because it's important, but it's actually more important as you get older in order to maintain your function. And I think oftentimes that gets missed. Okay. So next slide. So the benefits of age-friendly care, and this is based upon well-done studies that older adults do benefit from the age-friendly concept. Improved communication, okay, obviously the what matters, the two-way shared decision-making, improved satisfaction with care. The medical care is aimed more directly at what the goals of the patient or the client. Improved relationship with clinicians. I think that says what it means. Decreased medications. Okay, if you're looking at it, oftentimes medications management becomes easier. And this is an important one: less time devoted to daily medical tasks. We often, as clinicians, don't realize what we're asking our patients and clients to do, and it may be taking a great deal of time, not only for the patients, but also for the caregivers and families. So the challenge here is to make the care more connected. We have a fragmented healthcare system. We call it siloed. We have multiple organizations. Everyone's trying to do their best, but if we don't share the goals, the journey can be confusing, inefficient, or counterproductive. And again, everyone needs to know and recognize the 4 M's guide the care. It's not necessarily going to be evidence-based medicine, because these people have longevity. They're there. Now, what do you want this to look like? So The question we need to consider here is actually how do we move from the siloed care to a more cohesive system with better and shared outcomes? And I think that's partly, we're presenting this. We want you to figure it out.
Yeah. The impact of shared goals for you that are listening that have your business or organization that is working with older adults. If you're sharing goals, we have increased efficiency. You're not duplicating efforts within your own company, possibly, or even, across several different companies that might be working with a client. Partnerships become stronger with the patient and within the care ecosystem, and I'm going to come back to that word in just a minute. And we feel greater purpose if we're all working towards the same thing, which is that goal or the what matters for the client. It's very meaningful. It's very strong. So this age-friendly ecosystem, where we've been talking right now, is healthcare systems primarily. But if we look around us, we have a whole host of things that are part of any of us aging. I mean, what's our public health system like? What's the workplace like? How are communities set up for older adults, whether you're robust and healthy or whether you're frail and having difficulties? So this whole ecosystem, there are lots of different working parts. And I would suspect that many of you listening in, part of what you do might not be specifically in the healthcare system, but in one of these other realms of an age-friendly ecosystem, so that we're all working together. In Indiana itself, this was just something I saw recently, and it's not specifically on topic to the frail elderly, but it puts us at more risk. In Indiana, there was a study that was published in September of this year, and Indiana is the worst state for older adults seeking an active lifestyle. This is from the CDC, U.S. Bureau of Labor and Statistics, and the U.S. Census Bureau. Indiana ranked 44th in the nation for physically inactive seniors, with 36% reporting no leisure physical activity. 41st in life expectancy in the country, with an average of 7.17 years after the age of 65, where on average it should be at least 20. In Indiana, it's 17. And in Indiana, less access to gym and fitness centers per 100,000 seniors. We're 43rd in this category. This means there's lots of room for improvement out there. These are important categories, though, because if we're not being physically active, it increases our risk of becoming frail and increases our risk of having multiple chronic conditions and kind of going on that whole continuum that we showed that picture of earlier, and who we really, all of us together, need to try to pick up on. The barriers to having an age-friendly ecosystem, though, one of them is ageism. I mean, do you just walk into someone's home and see they're a bit confused today and say, oh, they're 90 years old, what can you expect? Well, if that's how they've been for the past, year, okay, maybe. But if that's not how they are when you normally see them, it's not okay. I mean, what's going on today? There is a true lack of knowledge of this whole age-friendly concept, and that's because it's new. So part of the reason for us doing this, consulting as we get older, is because we feel this information needs to be out there still. So our Healey's on Aging Consulting is really about educating on this topic. Part of the problem as well with the barriers to this whole thing are the silos that we've talked about. You might know this information, but the rest of the people that are in your company and work with this client know that whatever information, their goals, what matters. And how about if several of you are working in the same client's home? Are you all working towards the same goal? You probably don't even know what each other's goal, and ideally it should be what it is that comes out of that what matters discussion with someone. Of course, in terms of statewide and countrywide, there's always insufficient funding and insufficient infrastructure. Again, this is new. We don't know how to do it yet. We're going to work through just a quick example here. So we have Mrs. Johnson, who's 86 years old. Her primary language is English. Her social history, she is widowed. She has 2 daughters. She has a good relationship with her out-of-state daughter only, meaning she's not getting much care or help from her in-state daughter. She does live at home, though, with some supports. Her cognitive status is intact, meaning there's no concern about her memory or depression. She is continent of bowel and bladder most of the time, which means once in a while she might have an accident. She walks with a walker, a rolling walker, but it's really limited because she has a lot of pain and some balance issues. So Medically, she's got some pretty bad arthritis in her knees and her hips. So that's where this mobility problem really comes into play. She's got lung disease, she's got heart disease, she's on oxygen, blood pressure problems, type 2 diabetes, and she's had 2 falls in the last year. So she potentially is on lots of medications. There's lots of places that this lady could use some help within her home. What matters to her is she wants to remain in her own home. So, who's all coming into her home? I mean, so again, those of you listening in, are you her home health agency? Are you the nursing agency? Are you the non-medical part? Are you bringing in home meals? Is there transportation for her? Is there that elder law attorney out there available for her? Do we have real estate needs? Does she need home modifications? Does she need to move? Just because someone's goal is something, it doesn't mean that it can always be achievable either. Sometimes you have to rework what that is if it's truly not feasible, but you want to try to work towards that. Has anybody involved the area agency on aging? So I don't have any more specifics for you than that, but I'm just saying, okay, put in your head with your own particular business or company, what are you doing for this lady? Are there places that you could be connecting the dots more with other people so that you're all on the same page to make this work better for Mrs. Johnson? Again, most of us don't go looking into such things until we truly need the help. So did Mrs. Johnson and her family even call the right entity to begin with, or is she still missing a lot of supports that she really might, benefit from? It's always smoother if we're sharing this information. But there is not one, if you're that person out there in need today, there is not just one 1-800 call aging, what just puts you in line with everything you need. Now, the closest to that would be the Central Indiana Council on Aging. So I would recommend you call that. But for someone that doesn't even know to do that, where do you begin? And that's why, again, I feel like if we are all working to bet together, we may have better solutions. So how do we do these solutions? Those 4 M's. If those pieces are in your mind, that helps you to be able to talk the talk to that next person caring with her as well, even though maybe your part might only rely on the what matters, or maybe the mobility, or whatever the case. So today, what matters is that we are trying to look at how can we share these client goals. I mean, not all of you out there are doing all the work within your company because you may be limited to the home care and don't have the meals available, or whichever piece. So are you communicating with each other? If you are, wonderful. If not, how can you? And this is where we're empowering you to think about what you can do to make this care more seamless. So the vision really is all of us heading in the same direction for the client and their goals. So the call to action, let's connect. How do we embrace collaboration? How do your organizations talk to each other and move from being independent operations to an integrated client-centered approach? Doesn't mean you have to own all the pieces, just how do you communicate with each other? So here's where your opportunity is to help expand age-friendly care and the 4 M's. And we would love to hear from any of you in the future who are figuring out how to do it and what to do to make things better for all of us as we age, for our family members, for our clients, et cetera. Thank you so much, and we will be very happy to take any questions.
Well, that's great. One thing that I was sitting there thinking of as I was going through there, and Pat, I was going to say that I really liked the fact that we were talking about having someone get up and walk across the room and back and stuff, because most doctor's appointments are 6 or 7 minutes. You don't get a lot of attention. I know how important that is because my mom had been hiding her infirmities from me for quite some time. Okay. So, I would come and bring her groceries and I would do whatever was going on. She lived out, well, it was a farm, but it kind of got swallowed by suburbia. But anyway, but I would come over and I'd bring her stuff. Well, I never just used my key to walk in because I didn't want to startle her, out there. So I would always knock and then, she'd come and let me in. Well, all of a sudden I'm knocking and she's going, "Oh, the door's open, come on in," which was kind of weird. Okay, like what, why is the door open? Okay, whatever. And she would always be sitting in the exact same spot in her couch when I'd come in, and I'd do whatever I had to do. And then she'd never move from that spot, from the visit or what have you. And one day I was just like, well, I decided I was going to go wash her car because I would move it all the time so it looked like there was activity. Okay. And it had sap on it. Like, well, let's get this, cleaned up. And I go, is there anything you want from town? And she goes, I like a Big Mac. So great. So I pick up stuff. But instead of bringing it to her, I just went in and set things up on the dining room table. And that's when I found out, I'm like, oh my gosh, we have serious issues here, because that was what I forced her to have to get up and move. So, I mean, I think it was that same within the next week she was in assisted living, because we're like, she can't live out here by herself. But she had done a really good job of not letting me see that. So
And you make a great point, Jim. I mean, all of us are good at covering things up.
Yeah.
Yeah.
Whether it's intentionally or unintentionally, we get really good at covering things up. My similar kind of story is that years ago now, my parents, when they were alive, would drive a trailer across the country during the winter time, and they would end up at our driveway for a couple of days and stay in the trailer. And my kids would, again, years ago, my kids were young, and so the kids would go out and have breakfast with them in the trailer. Would you think the first year that they came for that visit, that mom didn't offer to cook breakfast and have them have breakfast in the trailer before school? Do you think the first thing that hit my head was, oh my, I wonder if we're having cognitive issues? No, it didn't occur to me. But as you look back, you're going, oh shoot, there was, I don't know for how many of you watched the Netflix show Man on the Inside, but
Yes.
we all need to be private investigators, right? And
Right.
ask those questions, look for those things, because people, that's why, again, it takes it takes a village here, right?
Right.
It really takes a village.
Well, in our world, where we're basically helping people downsize and pack and move, and maybe moving into assisted living and getting rid of all the extra stuff or what have you. One of the most common things I run into, I'm dealing with it right now, is that the family has not come to terms with where mom or dad is. Okay. So the very first thing, they're wanting to move them into independent living, which I can see is not the answer. Okay. So they've taken that first step, but they're not taking the step that they need to take. Sometimes you can get through to them. Sometimes you just go, okay, well, I'm going to be probably moving again in 2 weeks. But you try to get people to listen to you, but it's getting them to see what is in front of them, but they don't want to see.
Yeah, that's very, very common. And I'll bet you do see that because, that's another one of those kind of hidden things. It's extremely important, but, it's covered up,
And it's an ageist thing.
It is ageist.
In that we assume it's normal for age, therefore we don't really need to do a whole lot differently about it. So
Yeah. Well, the other things that you were talking about, things that can happen, like the dementia, the delirium. There's so many things that can cause that. It could be a urinary tract infection. It could be my father-in-law came across this. He had dementia, but he had COPD so bad that he was getting oxygen starved. Okay, and that was where that issue was. I had that experience, and because of him, I understood it better. Okay, when I had COVID back in March of 2020, I had it. Well, I made sure to get everything out of the way that year. I had COVID, and I had influenza A and influenza B all at the same time. It was a interesting 3 weeks, but I couldn't think. It was impossible. Everything was like my brain was made out of mud. I was hallucinating all the time, and it was just. And a friend of mine who it turns out happens to be a COVID research scientist, told me that COVID is basically your red blood cells can't transfer the oxygen into your cells. And so that all of a sudden I understood, because I knew my father-in-law's situation. My brain wasn't getting any oxygen. Okay. Now, I can tell you the happiest day of my life was that Friday morning when I woke up and I could think again. But, it was, because I had no idea. Nobody knew. Am I here now? But there's so many things that can cause it, so that's you don't just want to blow it off because it might be something that's an easy fix.
Yeah, that's a very good instance of an acute delirium, and lots of things can cause it. And the older we get, the less of an insult it takes for the brain not to work. And that's kind of scary because you went through it. I mean, and it is scary.
Terrifying.
It is, absolutely.
I can think well enough to know I can't think.
Yeah.
Yeah.
Well, that means you don't have dementia, you have delirium.
Mhm. Yeah, but but those things, but trying to get people to understand that's what I think that we all as a team are trying to figure out how to navigate, and create that safe space.
And then, back to the whole thing on, team. I mean, we all need to be team for individual clients or patients or whomever you're talking about, even if you aren't normally part of the quote same team. So how are you going to communicate? I mean, how are we all going to know when we're in Mrs. Johnson's house, what her goals are? Do we each have to ask? Well, for your own business, you probably need to know what that goal is, but what's her overall goal? And so how are we sharing that? That's where all of you need to figure out what what works, and what works here in Indianapolis or Indiana may not work some other state or city, et cetera. So what everybody does may be a bit different. The I think important thing is do something. Let's figure out what it takes, because it's not out there for you already. Because again, this is all new stuff. So we're all on the cusp of figuring out how to do it and do it well, hopefully.
Well, thank you so much for coming and sharing with us. This was a lot of fun. I really enjoyed this, and so I will get you a copy of this video so you can do with it as you please. But I'm thrilled that you guys came and shared with us today.
Well, great. Thanks for having us. You're doing a great job. We appreciate the co-pilots. That's great for everybody out there. Yep.
Well, hopefully it's at least a source that people can go to that nobody's trying to sell them anything.
Right.
Yeah. So, all right. I'll see you guys later.
Okay.
All right.
Thanks so much.
Take care.
Bye-bye.
Bye-bye.